A very warm good evening to one and all. I welcome you all on behalf of IAS, STD, and AIDS to this Astinar-6 program. Today, I welcome our organizing secretary, Dr. Bhumesh Kumar sir, to say a few remarks.
Yeah, thank you, Dr. Kavita, and good evening to one and all, and welcome to the Astinar-6. The topic of this Astinar-6 is the management challenges of sexual dysfunctions in men and women. We have a renowned faculty from all over India, and the importance of this Astinar is one side we are creating awareness on the academic activities on the genital health, and another side we are sensitizing the PGs and SRs by quiz and to motivating, especially in the field of STDs and AIDS. And not only that, we are taking the senior faculty members to create genital health awareness as a Astinar star. So just like our beautiful tricolor flag, so these are the three ways we are going to sensitize. So today we have eminent speakers to sensitize on the sexual health, because people can tolerate the tragedy of earthquakes, calamities, anything, but nobody can tolerate the tragedy of bedroom. So it is a high time to sensitize more and more and keep that sparkle alive. With these remarks, and I request Dr. Kavita to take over and do the proceedings for the further proceedings. Over to Dr. Kavita.
Thank you, sir. I now request our organizing chairman, Dr. G. Narasimharao Neta, sir, to kindly say a few words.
Thank you, madam. Very good evening. Respected National IAS, STD and AIDS President Dr. Murugan Garu, National General Secretary Dr. Mohan Kumar Garu, Treasurer Dr. Chandrasekhar Rao Garu, Organizing Secretary Dr. Bhumesh Katakam Garu, and my dear IADWLites, on behalf of IAS, STD and AIDS, I welcome to all for Astinar-6 is being held today. In this, what I came to know that there are lack of much awareness and new knowledge about the sexual health. So this is the right time, I think, because as you all know, sexual health is a fundamental aspect of physical and mental well-being. About these statistics, around 43% of women, 31% of men are suffering from some form of sexual dysfunction. Most commonly, males are sexual disorders are due to premature ejaculation. In females, most commonly, sexual disorder is because of the arousal disorders. Sexual dysfunction can be heightened by biological, psychological, social, and environmental risk factors, including diabetes mellitus, excess use of alcohol, hormonal imbalance, trauma, and cardiovascular diseases, and other chronic diseases leading to the sexual dysfunction. Treatment needs integral biological and psychological interventions like hormone treatments, pharmacological treatments, or surgical treatments, psychotherapy, or so on, sex therapy, like that. Sexual medicine is evolving, expanding, and advancing with recent strides in pharmacology, psychology, and relationship counseling that focusing on couple for healthy sexual life. So this is the high time to sensitize ourselves regarding the sexual health and medicine to treat needy of the society. I congratulate all faculty members for your contribution, and also thanks to participants of this Astinar-6 and making its grand success. I humbly request senior members to encourage postgraduates to take membership and active participation of CME programs, and also for the enrollment for the ASTICON 2022, which is to be held in Hyderabad in September 8, 9, 10. I express gratitude to Hetero Pharma Group for sponsoring this academic program. Thank you one and all. I will hand over to Dr. Bhumesh for further proceedings. Thank you. Thank you very much.
Thank you, sir. Thank you so much, sir. I now request our President, sir, Dr. Murugan, sir, to kindly address.
Thank you, Dr. Kavita. Good evening, everybody. I welcome you all to this wonderful evening, Astinar-6. Today's topic is the management challenges of sexual dysfunction. Be dermatologist, what is the role of sexual dysfunction? When you are recognized that you are seeing genitals and you are handling genital problems, then the sexual problems will approach to you. The sexual problem is increasing day by day, and it will be there as long as the human kind is exist. The lifestyle and various types of modification are changing, so the problems also are increasing, are changing at new dimensions. So everybody has to be aware, and we have to tackle these cases. The sexual problems is handled by urologists, psychiatrists, gynecologists, and also dermatovenerologists. But thing is, it may be psychosexual as told by Dr. Narasimha Netaji. It may be psychosexual, it may be organic, it may be drug-induced, or so many things. And if it is organic or surgical importance, urologist can handle. And if it is sometimes psychiatrist, some of the drugs may worsen the condition. And we dermatovenerologists, gynecologists also very busy in their practice, so they may not be able to spare time to handle these cases. And we dermatovenerologists already has been experienced with counseling with so many diseases, HIV, STI, and so many genodermatological things and very chronic manifestations of the dermatology conditions. So we will be able to spare, and we will be able to concentrate, we will be able to understand the problem and can handle the things better than anybody else. So it is a very important subject, sexual dysfunction. Today we are having wonderful moderators to handle these sessions, panel discussion, and extreme good panelists are there. So we have to utilize this opportunity, and we will have a wonderful scientific feast today. And as Dr. Narasimha Netaji told, the Asticon 2022 is coming. We are counting the days, September 9th, 10th, 11th. And those who are not yet registered, please update and register yourself and make your plans correctly. And those who are not becoming IAS members, please join this association, and it will be valuable for your contribution will be very valuable for this association. So with these few words, I will complete, and I will hand over the mic to Dr. Kavita for further proceedings. Thank you very much.
Thank you so much, sir.
Kavita, 1 minute. Just a small change in the pattern because of Dr. Venkatramana sir, the technical problem, he could not, it will take some time. Now we will start with the female sexual panel by Dr. Padmini. Yeah, Kavita, go ahead. First.
Madam, are you ready, madam?
Yes, yes.
Okay.
No problem.
Dr. Kavita.
Yes, sir. 1 minute.
Chairperson.
So chairpersons will change.
No problem. You introduce the chairpersons 1 and 2. First chairperson will introduce Dr. Padmini, ma'am, and second chairperson will introduce. Yeah, that is not a problem.
Okay. I now request our chairpersons, Dr. V.V. Pai, sir. Kindly, technical team, display the Dr. V.V. Pai, sir. He is the director of Bombay Leprosy Project. To his credit, he has many publications and achievements and awards. So I request V.V. Pai to kindly grace this Astinar, sir. And I also request Dr. S. Suryanarayana, sir, former professor of Gandhi and Usmania Medical College, now working at MNR Medical College. Sir, kindly start the proceedings, sir. To start with the management challenges of female sexual dysfunction. Over to Suryanarayan, sir. Sir, unmute, sir.
Okay. Good evening, my friends and colleagues, and very knowledgeable evening I expect for the PGs and the faculty from the moderators and panelists. And it is giving me the great pleasure to be a chairperson for this session, evening session. And I will introduce the first topic is management of female sexual dysfunctions and challenges of the female sexual dysfunction. And I introduce Dr. Pani Prasad, moderator for this session, and it gives me a pleasure to narrate her credentials. She is consultant in obstetrics and gynecology, and she is sexologist also and marriage counselor. She has the following credentials. She is a medical director for Ramamani Nursing Home, Maternity Home, Institute of Sexual Medicine, Bangalore. And she is past president of Bangalore Society of Obstetrics and Gynecology. And the theme of it is Women's Health Speak in Unspoken. And she is chairperson for Sexual Medicine and STDs Committee, KSOG 2122. She is member of World Association for Sexual Health, and she is committee member for Sexual Education, International Society for Sexual Medicine, ISSM 2022. She is secretary for Council of Sex Education and Parenthood International 2023, and she is national coordinator for Sexual Medicine Committee, FOXY 2020 and 21. Sorry, 2020-22. She is a co-opted member of National Family Planning Association of India 2021-23, and she is secretary vice president formerly for Society of Obstetrics and Gynecology. She is vice president formerly for Family Planning Association of India. She is gold medalist of MD and in Obstetrics and Gynecology, and she is a recipient of numerous awards. Felicitations, Rajyotsava, Kempegowda and Rani Chennamma, etc. from Government of Karnataka. She has Golden Lamp Award and Silver Lamp Awards from CSCPI, and she is author of 11 books on sexual and reproductive health in Kannada and English, both languages. Regularly, she is featured on television, radio on sexual and reproductive health awareness program, and she is faculty in national and international conferences on obstetrics, gynecology, and sexual medicine. It gives me great pleasure in introducing her for the present day's discussion as a moderator. And now I will introduce the panelists of this session. Dr. Neelima.
Panelist will be introduced by moderator, sir.
Moderator. Okay, sir. Right. Thank you. So now I will hand over mic to moderator to proceed this session. Thanks, sir.
Ellarigu namaskara. Very good evening to you all. Thank you very much for the kind and generous introduction. I would like to thank Astinar for giving me this wonderful opportunity. I would like to thank wholeheartedly for this wonderful opportunity to meet people from different places and also different specialities.
Padmini madam, just you introduce your panelists in a, just
Yes,
briefly
yes,
introduce.
That's what I'm doing. If I'll just
Yeah.
come to that. But I'm just thanking you all for this very good opportunity to meet you all and very exciting. And today's topic is an panel discussion and the discussion about these challenges on female sexual dysfunction. For that, I'll be the moderator, and we have our esteemed panelists, Dr. Nilima Deshpande, Dr. S. Vasuki, Dr. M.H. Sobani, Dr. Prasanna Gadre. And it gives me great pleasure to introduce all such, with all the, what to say, that such a good CV which they have, which are powerful, or what the great work they are doing. When I was going through all these CVs, I was really feeling that such impressive CVs they have, and they are doing such good work. And Dr. Nilima Deshpande, Gynecology, Menopause, Sexual and Reproductive Health, Holistic Health for Women. She is a speaker, trainer, author, coach, and entrepreneur. And she is a Finance Committee member, ISSM 2021-23, Joint Secretary, IASM PMM 2019. 3 decades of international experience in women's healthcare, and she created systematic treatment plan for women over 40 years. And she is obsessed with demystifying health and wellness for women. She is the author of Menopause Made Easy, with 121 tips to guide and inspire. And she is a postgraduate teacher, trainer in OBGYN and SRH since 1993. And our next panelist, Dr. Vasuki. She is a professor, Department of Dermatovenerology, KAP Government Medical College, Trichy. And her important achievements include she is the member of FOXY, IASSTD publications in national journals, attended national conferences on HIV, STD, dermatology, and OJS speaker, chairperson, delegate, received award from district collector for performing more number of HIV positive deliveries in the private sector. And next, welcome Dr. M.H. Sobani, who is a consultant, Skin Hair Clinic, Mumbai, ex-clinical associate, Jaslok Hospital, ex-consultant, Kaya Skin Clinic, and Dr. Prasanna Gadre, who is also a member of CSCPI. Very happy to introduce him with such impressive CV he has. 28 years in practice of sexual medicine, cosmetology, aesthetics, and dermatology. He has been to UK, USA, South Korea for clinical observership in genitourinary medicine, lasers, and cosmetology. He has authored 3 books for skin, masturbation, and pioneering work, and book on how parents should talk to kids as regards sex and sexuality, titled as Hello Sexuality. Corporate HR. He is the life member of Aging, Gender, Andrology, and Sexual Sciences Society of India, member of CSCPI, has podcast on Swedish podcast company Storytel, Marathi Kata for sex education, titled Sex War Bol Bindas, which for last 4 years has consistent highest ratings and hits. YouTube channel as Prasanna Gadre on sexual, skin, hair, mind, spirituality related topics, and same on BBC Marathi News. So coming to this female sexuality, because of the lack of time, I have to go a little faster also. So female sexuality, sexual health as such, is an sexual health and function are important determinants of quality of life. And female sexuality was a non-entity till few years ago, but with increased awareness, education, employment, and thinking capacity of the woman, so she has also become aware of her sexual needs, concerns, and the problems which can lead to frustration and problem, anxiety, depression, etc. And present day, the earlier, only the man used to come for sexual dysfunctions, and nowadays the woman is bringing the man for sexual problems and for consultations, telling that I am not enjoying, my husband is not satisfying me, he is not having, he discharges very fast, and his organ is not raising, so many of that. And when you should also understand the colloquial languages in which they describe, so that you will understand why they have come to you, and you have to detect the sexual dysfunction in the woman. So it becomes very important for every person to make the sexual history as part of overall history, because any disease, operation, medication can disturb the sexual functioning and can lead to disturbed relationship. So the sexuality is defined as a central aspect of being human throughout life. It encompasses sex, gender identities and roles, sexual orientation, eroticism, pleasure, intimacy, and reproduction. Sexuality is experienced and expressed in thoughts, fantasies, desires, beliefs, attitudes, values, behaviors, practices, roles, and relationships. While sexuality can include all of these dimensions, not all of them are always experienced or expressed. Sexuality is influenced by the interaction of biological, psychological, social, economic, political, cultural, legal, historical, religious, and spiritual factor. So sex is not just a simple thing. So there is the psychological component, physical component, and various other components which are acting on that. So the mind, body, and soul, that's the combination. So it is a state of physical, emotional, mental, and social well-being in relation to sexuality. You also should know that sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. For this, sexual rights of all persons must be respected, protected, and fulfilled. And sexual health is for procreation, recreation, and also relation. And this sexual response depends on a complex interplay of physical, psychological, and emotional factors between two persons. It is coordinated by the neurologic, vascular, and endocrine systems, and influenced by family, society, and religious beliefs. So now coming to this, I will go on to my panelist, Dr. Neelima Deshpande. What is the female sexual response cycle? So unless you know this, the sexual response cycle, it is very difficult to understand what is sexual dysfunction. Once you understand the simple female sexual response cycle and the various events, it becomes easier for anybody to diagnose and come to conclusion where exactly is the problem. Can Dr. Neelima Deshpande explain what is female sexual response cycle?
Thank you. Thank you for having me on this panel. So the female sexual response cycle is the way the woman responds to sexual stimuli that may happen either in interaction with her partner or in response to a process like masturbation. So the first part of that cycle is about desire. So the woman actually wanting or wishing to engage in sexual activity. And as she proceeds through this desire, she gets aroused. So the second phase is the sequence of arousal, where there is congestion of the genitalia, there may be erection of the nipples. So there is a genital response as well as a general physical response that happens because of arousal. Then this is followed by the phase where there is actual intercourse or intromission, where there is penovaginal intercourse. And then during this phase, we may have what's called a plateau phase or an excitement phase, which is then accompanied by orgasm. And after orgasm, there is a resolution.
Yes. Dr. Vasuki, can you explain me the events and the phases of the sexual response cycle?
Thank you, madam. Thank you for the opportunity. Already Dr. Neelima was talking about the various phases. So after a initial sexual desire, that may be a spontaneous one or a responsive one after a sexual stimulation. The woman has the desire and willing to participate in the sexual activity. Then comes the arousal, wherein the vasocongestion and the neuromuscular tone causes changes in the genitalia, as well as systemically, causing lubrication in the vagina and the genital swelling. And then comes the stage of vaginal penetration or intromission, and the orgasm. And the next stage is the orgasm or climax, where the sense of well-being will be there in the woman.
And you can see in this, there is a difference between the male and the female. So there is excitement, plateau phase, orgasm, and then resolution at the height of plateau phase, and it reaches the orgasm. So, but in the man, this can be a straightforward thing: excitement, plateau, orgasm, and resolution. But in a woman, there can be varieties or variations. The woman is capable of having multiple orgasms. Woman sometimes happens, she can just stop short of the orgasm at the pre-orgasmic level with a slow resolution. She may not reach the orgasm, or there can be sudden heightened response and sudden arousal, excitement, and also sudden resolution. So these various variations are possible for the woman. And Dr. Sobani, what is female sexual dysfunction? How are they classified? Dr. Sobani is here.
Yes, I'm here. Yeah.
Yeah, thank you. Welcome to the panel, and please describe us what exactly is the female sexual dysfunction.
Thank you. Now, female sexual dysfunction is defined as any disturbance in the sexual functioning of a female. Okay. Now, as it was described previously, that there are areas of desire, arousal, penetration, and orgasm. So these are the phases which was described, but definition is disturbance in sexual functioning of the female. So classification would be a desire disorder, arousal disorder, orgasmic disorder, and sexual pain disorder. Okay. Now, as per the classification, now DSM-4, and now it has changed to DSM-5. Now, DSM-4 had female hypoactive desire disorder and female arousal disorder. Now, that has been changed to, in DSM-5, both have been merged, and it's called as a female sexual interest and arousal disorder. Whereas in female orgasmic disorder, it is unchanged. In DSM-5, it is female orgasmic disorder. And now in that pain disorder, there's a dyspareunia and vaginismus, which has merged into genitopelvic pain and also penetration disorder. So this has been combined with DSM-5. This is the change in DSM-5. Now the requirements are the sexual dysfunction should be minimum of 6 month duration, and frequency should be 75 to 100%. And exception is substance or medication induced disorders. This is how it is classified.
Thank you very much. So you could make out what are the requirements to call it as a disorder. There can be just a disturbance, there can be a dysfunction, there can be a distress. So depending on this, when you really call it as a disorder, sexual desire disorder or any disorder, it should qualify all these factors. Coming to Dr. Prasanna, can you please explain to me how common is FSD and how commonly you are seeing female sexual dysfunction, and what is libido?
Yeah,
how do you describe
sure. Yeah, sure. Definitely, I would like to share my thoughts. And I think it depends more of on the specialty, because as a gynecologist, you will be seeing more. But as a dermatologist, I would say almost 70% are the male patients who come to my clinic, and 30% who are the females who come to my clinic. Now, if you take a global view, starting from India, I would say that I think TSS Rao and his colleagues had made research survey where almost 10 to 15% was there in a incidence was there in a rural to semi-rural areas. And if you go from America to directly to Japan, you will get different statistical rates ranging from 30, 40, 50% to almost 76%. But on an average, I would say that 30 to 40% is the rate. And the unfortunate part of the story and the saga of the suffering of the society is that even the sexuality or the sexology is so sexist that only male happen to go in a more number, while females just do not report. So it's like an iceberg phenomenon, and we never know the real picture. But I would say that 30% on an average is what we get if we take the statistics. But from 2012, I am seeing a change within last 10 years that more and more females are also started reporting and coming to the sexology clinic.
Yes, there is many a change in the
Yes,
attitude and then expectation and the concern.
Yes,
So doctors have to be more, they should have updated knowledge on the sexual functioning and also dysfunction. So what is this? What is libido? So many times we keep on saying she has got reduced libido.
Sure.
Yeah,
I would definitely share this because this is a very interesting thing or a phenomenon. Is it possible, may I request the technical person to switch it on the speaker view? Is it possible, or we are supposed to go in this frame? Can you please let me know?
Yeah, because we have to stick to the timings, no? If
Okay, sure. Absolutely no problem. Yeah, absolutely no problem.
We would love to do that, but
sure. So the thing is that basically, in case of libido, the word has been derived. The Proto-Indo-European origin is from lubos, which actually means care and love, while the Latin origin comes from the word libidos, which actually means the inordinate desire, the sexual lust, the sexual passion. Freud, Karl Graf Ebings, and A. Brill were the three scientists and the psychosexologists, I would say, who introduced this term from 1892, and they revised it and they propagated it throughout the world till 1930. And actually, it means that it's a bio, psycho, sexual, and physiological energy, a part of our life instinct, which has the intentionality to perpetuate the species, and basically which gives all sort of sexual sensations, emotions, feelings, perceptions, and ultimately drives the body to participate in a sexual interaction and an act or a sexual behavior. So we can say that basically it's an energy that motivates the person to do the sexual activity.
That is the willingness to participate in sexual activity.
Yes.
Okay. So a few of these things which can describe what type of, now that you understood what is sexual response cycle and the various desire, arousal, orgasm, and intromission, etc. And a few of these case scenarios. Suma and Satish are married for 4 years, and Satish has a complaint that Suma has no interest in sex. Even if the frequency is once in 3 to 4 weeks, she reluctantly participates in sexual intercourse. What exactly is this desire? Can Dr. Neelima describe that to me?
So in this particular case, there is a complaint from one partner that the other partner doesn't seem to have any interest in sex. So even though the index case is actually the lady, who has lost interest or doesn't participate because of whatever reasons, the complainant is actually the male partner.
Yes.
So it may be that there is a discrepancy, but unless we go deeper into taking the history of this couple, how it started, or has this been...
So it speaks about the desire disorder. We will come to the details little later. So it is you are very correct that it is that's how this is how they may present, because there is various different ways of presenting. This is one way of presenting. The husband comes and complains that she has no interest, and whatever we do, there are various reasons for not having the desire. So coming to the another case, Geeta, she complains of burning during intercourse. She has no interest in sex. She often quarrels with her husband, Prakash. Dr. Vasuki, what exactly is this?
So from this case scenario, I got 3 points. One is pain or burning sensation during intercourse, no sexual desire, and quarreling. So this seems to be an arousal disorder as far as me, but we have to get into the history whether she has desire, thoughts, sexual fantasies like that, and we should go for
Yes.
whether she is having lubrication like that, we should ask. And also,
So why is, see, one is leading to the other. There is a lack of arousal, that she complaints of burning and then not having the interest. So one can lead to the other. There can be an interchange in various phases. There can be arousal, desire disorder can come later, and also dyspareunia, all combined in this problem. So we have to get into the depth of it. Dr. Sobani, that's the third case. Leela worries that she has not enjoyed sex from the time of her marriage. She does not feel it as pleasurable as it is described by her friends. What exactly it tells?
Yeah, now this case of Leela, I would tell you a similar case which I was handling. It will make it little more clearer.
Yes.
Lady, 45-year-old, coming to my clinic, and she was married to a accountant. She had 3 children, married for almost 25 years. So she was having itching problem, and I felt there is some psychosomatic problem. On discussion, when I went deep into the history, I asked her. She said that they were staying originally in joint family, and now the mother-in-law, father have died. Last year, when she was with the husband and children, one of the husband's brother's son came from the village, and he was going to US. And that's that his husband used to work from 8 a.m. to 9 p.m. in the night and would not devote time to her.
Yes.
And when this gentleman, this boy came to go to US, they stayed in their house. He happened to have sexual intercourse with this lady. And then she enjoyed sex with him. And after that, he left for US, and then she was coming to me, and she has this psychosomatic problem. So she opened up and said that I did not enjoy sex for last 20 years with my husband because he would come in the night tired, and he would just, when he has a desire and he has penile erection, he would just remove my underwear and penetrate and discharge and go back to sleep because he enjoyed and he finished, and he never took care of my interest. So she never reached orgasm.
Yeah, that is an orgasmic disorder. So that there are reasons for that.
Correct.
So why she was not enjoying, not properly stimulated by the husband. Dr. Prasanna, this is the fourth case where we know that Veena are married for 5 years. They come for treatment of infertility. Veena complains of pain during intercourse.
Yes.
Yeah.
So basically the thing is that coming to the algorithmic approach, we have 2 things, infertility and pain during coitus. So the thing is that infertility could be because there is no proper intromission only, where the penis has not gone into the vagina because the pain which he suffers. And this could be because of the dyspareunia or the vaginismus or any other genital related causes. So it appears to be definitely more of organic, but we should always keep in mind that the psychological components are not there, because what happens, even though the organic is there, each and everything I would say is a psychosexual. Once the organic thing is there, it triggers all the psychosexual emotions of fear and anxiety, and that also can add to the problem. And of course, things like pregnancy phobia, coitophobia, and lack of maternal instinct, etc., should be ruled out. But this appears to be definitely a problem to the passage of the vulva vagina.
So more probable because it is also caused infertility, and she is complaining, and maybe a case of vaginis or penetration problem.
Yeah. Yes. And the thing is that we should rule out whether it's a primary or a secondary infertility, because that's a game changer.
Yes.
Okay.
So this is the case. Anybody can take it up. The Kamala has stopped menstruation since 4 years, and her husband has a complaint that she does not cooperate in sex. He is frustrated. So this is a very common thing which comes in the postmenopausal with the decreased estrogen level and having a problem. And culturally also, many of the women think that the end of menstruation or the menopause is the end of sexual life. So somebody can describe it, how they come and how they present, and this postmenopausal sexual dysfunction.
Yeah. Nilima, you can go ahead.
So women who go through menopause, like you said, ma'am, they often think that that is the end of their sexual life. They have children who are having children. So they think, oh, now I've become a grandmother, so I don't need to have sex, or they don't actually have desire because they may also have pain and discomfort with intercourse. They may have burning and stinging because of dryness that happens during menopause. Additionally, around this time, this age, once women stop having periods, and I'm assuming that Kamala is menopausal,
Yes.
and not because of any other reason.
She is postmenopausal, 4 years postmenopausal.
Yeah. So often it so happens that they have other medical issues also happening at the
Yes.
same time: diabetes, hypertension, they may have prolapse, they may have incontinence issues. So these never get explored. And even though the husbands often present saying that the woman is not compliant, nobody has actually asked the woman. And many times these women would not have seen a doctor since their delivery. So they don't have this concept of going for regular
Severe
checkup.
menopausal symptoms itself also can be causing the decreased desire and
insomnia, depression, anxiety.
Yeah, madam, can I contribute a small thing?
Definitely.
Yeah. So the thing is that there are a lot of cognitive errors, biases, and beliefs in the minds of the women as well as men. As I said, many people have this in mind कि age हो गया तो अभी खत्म हो गया सब sex. I think that's the greatest disbelief, because sexuality or sexual interaction has nothing to do, number one, with the age, but it is related to the vritti, the attitude looking toward the sex, and whether it is as a pleasure or failure. And second, and the second thing is that many a times people have this in their mind, like equation that penis plus vagina is equal to sex, or erection ejaculation is sex. But they should come out of this mentality and see to it that lot of touch, togetherness, and intimacy is celebrated in the sexual interaction. I think that is more important.
Yes, part of oral thing. You are very correct. Many people come under till what age we can have sex. So I just tell them one word: as long as you are alive.
Yes.
So that is what it is. Yes, we come to these different disorders in a little more detail. Dr. Nilima, can you explain me the sexual desire disorder? What causes this? What are the factors, and how you evaluate for this?
Sexual desire disorders in particular are hypoactive, decreased desire. So there is a persistent deficiency or absence of sexual thoughts. So that spontaneous thoughts that allow this woman to actually engage in physical sexual activity are decreased. So they have decreased fantasies, decreased sexual thoughts, decreased spontaneous sexual thoughts, or need to actually interact or seek out sexual activity. And this decrease actually is causing interpersonal problems in that couple, or causing difficulty or distress to the person themselves. So
what are these causes of desire disorder? What causes this desire disorder?
There are several causes. If we consider that some women have naturally low desire, so we call those women as having constitutionally low desire, and you can see this discrepancy in many couples.
This is very important, because so many times there is disparity between the husband and wife. Biologically, they may be having low desire.
So that what is normal for that woman can only be elicited once we take a history. In that history, we have to explore their physical causes. So any kind of genital or physical illness, any distress that they're having, look at psychological causes that may be interfering with that person, take a history about their menstrual history, their family history, interpersonal relationships, sometimes even financial causes. We know that relationship distress and financial discrepancies or financial distress is closely related to sexual problems in the couple. So we have to go through this kind of history taking to explore what might be the causes for decreased desire in women. And as women go through menopause, particularly, they find that decreasing hormone levels, especially both estrogen and testosterone, decline. So this also contributes to decreasing desire as women go through menopause.
Yeah. So in the form of treatment for all these disorders, first thing is education, counseling, and telling about that.
Yes.
Yeah. Tell me that about how you go about treating that. Once you evaluate it properly, you will come to know that what exactly is the reason.
Yes, with history taking, and history taking includes history taking not just of the lady but also of the husband. So I do a detailed history taking of partners separately and together. I explore their individual medical history, so to find out any contributing factors. Also take a couple history, a detailed sexual history of their interaction, how they met, what is their relationship like, how do they actually engage in sexual activity, and what get to the nitty-gritty of what actually happens when they interact. In the individual history taking, go back to their, again, medical history, also masturbation history, their childhood exposure, any kind of exposure or learning they have had from their family. So how the mother responded, in case of women, how the mother or the father responded to a girl menstruating, what kind of learning she had in school, first or early sexual.
Orthodox outlook in the family, and then not talking about this, and all these things are part of the design. So, Dr. Vasuki, can you describe this arousal disorder?
So in sexual arousal disorder, there will be inadequate lubrication and genital swelling that causes marked distress and difficulty in sexual functioning, and that may be subjective and genital, and it may be a combined one. Causes of this sexual arousal disorder is mainly improper technique and inadequate sexual stimulation. Of course, we have to rule out the other general causes what we have been seen now, like the medications, like the chronic conditions, etc. And relationship problem is a conflict between husband and wife may cause arousal disorder. In the case study also, that case study relationship problem was pointed out. And in this, it may be vice versa also. The inadequate and unsatisfied previous sexual experience with the partner may be a cause of a conflict, and that may be again lead on to arousal disorder. And it may be dyspareunia causing arousal disorder, and the organic causes, menopause, trauma, infections, anything can cause an arousal disorder. And in treatment, like in any sexual dysfunction, education and counseling is very important, touching on all aspects of the causes. And lubricants, and moisturizer, vaginal lubricants and moisturizers can be of help.
Thank you. Yeah, so there can be various reasons with the arousal disorder. So orgasmic disorder, as Dr. Sobani was describing the case which came to him also. Can you please tell me or describe orgasmic disorder in little more detail, and what may be the causes and how do you treat such conditions? Dr. Sobani, please.
Now, orgasmic disorder, it is a persistence, absence of orgasm after normal excitement phase. So after the woman is experience excitement phase, there is no orgasm coming at all. So this is how it is described, and the causes, what we see as a medical doctor, the organic causes, the biggest cause I find is diabetes, number one. And especially after the age of 65, uncontrolled diabetes, I find a lot of women become anorgasmic. Okay? Yeah. So this is the most common cause I find in my practice. Second most common cause is the menopause, where the hormones levels fall, and because of dryness of vagina, because of improper knowledge in the husband, the lady complains of pain, low desire, low estrogen level, and slowly she abstains sex. And then because she abstains sex, eventually the whole cycle repeats, and then she becomes not doing sex at all, and then she does not enjoy, or it's a painful thing, and so she would never reach orgasm. Then the third thing is some of the antidepressants also would cause she will not get orgasm because of those medicine. So we have to give her some other medicine which works as an antidepressant but does not block the orgasm. One of the very common thing I have found in some females who are on oral contraceptive. So when they are on oral contraceptive, they say they are not getting orgasm, or the orgasm is delayed. So this is my own personal finding. Now, coming back to the non-organic causes of orgasmic disorder is, I'll tell you a case which I found is improper technique. Now, 15 years back, I had a young couple who were both IT engineers. They got married, and after 3 years, they visited my clinic for. She was not conceiving, so she said that we are looking for a baby. We are married for 3 years. So on simple history taking and asking them questions, I was shocked that the man was penetrating in the thighs. So I asked for the question of lubrication during penetration. He said, no, there's never a lubrication. So I said, then how? Then he said, then I told him, so I could identify that he's penetrating in the thighs. Married for 3 years, it was the biggest shock to my life. So it is an ignorance. So
Yes.
in organ, the most common problem, not common problem, but one of the keys then there are negative attitudes, there are false expectation, and another one is sexual abuse. If the lady has been abused sexually during childhood, many times she has aversion and she cannot reach orgasm, and she cannot successfully complete the intercourse also. And of course, the most common is interpersonal relationship. If there's no good interpersonal relationship, then also we find that the orgasm doesn't come that soon. Now, coming to the management, of course, for diabetes, we need to control diabetes. Menopause, we need to handle that issue of low estrogen, coming to depression, we need to use drugs which do not cause this problem. And of course, it's not very common, but if there's a clitoral phimosis, then also the woman may not reach orgasm. So education, counseling, in treatment, directed masturbation, then erotic fantasization, body journey. Lady has to be comfortable with her body journey. Then, of course, comes mechanical aids, vibrators, then manual clitoral stimulation with the partner, and then the sensate focus exercises. So where we refocus, because lot of people in the bed are almost directly going into the penetration and without those initial steps. So obviously we have to put a focus on pre-intermission arousal. All that has to be properly handled. Otherwise,
I very nicely described Dr. Sobani about the orgasmic disorder. And coming to be probably because of the lack of time, we may have to go a little faster and being crisp. Dr. Prasanna Gadre, can you describe the sexual pain disorders?
Yeah, sure. I would say that basically they can be classified into three types as such. Number one is the dyspareunia. Second is the vaginismus, which is functional. Dyspareunia is more of organic. And sometimes there is something called as an hyperesthesia, right from vulvodynia to things like herpes zoster has become very common, and herpes simplex, which can cause the aesthesia, the hyperesthesia. Now, coming to the dyspareunia part, a lot of skin disorders like psoriasis, lichen planus, fungal infections, severely infected scabies, and even the lice can cause a superficial dyspareunia. Vulvovaginitis, most of the time monilial, which is related to diabetes, which is becoming common now in the younger age. And of course, the deep level, middle and deep level dyspareunia, where thrusting problems are there, where the gynecologist people would be coming across. That is the locoregional problems, right from cul-de-sac to the entire pelvic organ system. And I would like to say that in all sexual disorders, the three histories are very important, which is becoming very common in girls. That is the history of alcohol, hookah, and cigarette smoking. That is badly affecting each and every part. And coming to the vaginismus, basically it's a automatic subconscious contraction of the vaginal muscles, and that is because of a lot of phobias, as I had expressed. And these girls are basically not open for any kind of experience. That means the role of personality. They are shy, they are having guilt, they are having some shame, they are having the trauma, as has been told. All this psychology and the personality it affects, it has a shadow on the sexuality of the women. And that gives rise to automatic contraction. Say, for example, how the parents have taught her and how open is the atmosphere. So right from that to the things like sexual abuse and basically neurotic personality can give rise to things like vaginismus. So this is what I actually happen to come into practice.
Yeah. So this vaginismus, one thing people have to understand is vaginismus is very common. And earlier days it was not diagnosed, and now every gynecologist and even if they come to skin dermatologist, they should understand what is vaginismus. If she starts complaining repeatedly, not cooperating for intercourse, repeatedly complaining, and then of fear or pain, or if she is not willing for any pelvic examination, all these things are indirect indication that she may be suffering from vaginismus, and it is a very common condition for non-consummation of marriage. That's why most of them are detected at the time of infertility. So this is the three components. There is a fear, there is pain, and there is muscle spasm. So all these things have to be tackled when you are dealing with vaginismus. So the management of dyspareunia or the vaginismus depends on the cause also, and ultimately, like anything, education and explaining to them, desensitization, all these things become important. So this perimenopausal dysfunction, Dr. Neelima, can you quickly say what exactly is perimenopausal sexual dysfunction? We briefly described it earlier. Yeah.
So menopause is by definition is when the woman doesn't have periods for 12 consecutive months, and perimenopause is the time period. It can extend 5 to 7 years on either side of this, and it is accompanied by decreasing estrogen levels in particular. And therefore what happens is that the vaginal area, all of the genital area which has receptors for estrogen, becomes dry. Sometimes there is shortening in the length of the vagina, there is bladder sensitivity, there may be new onset incontinence. Around menopause, there is also an effect on the psychology. So the woman experiences decreased sexual desire, libido, there's irritability, there may be depression, anxiety, fear associated, not just with sexual activity, but with other things. And of course, there is physical symptoms. So hot flushes, pains, migrating aches and pains, low energy levels, tiredness, and other problems like diabetes and hypertension, which creep in. She may have palpitations also. All of these different aspects, these three particular aspects, physical, psychological, and urogenital, affect her ability to interact with sex and with her partner.
Dr. Vasuki, is hormonal treatment safe? We call it as menopausal hormone treatment rather than hormone replacement therapy these days. So whether the systemic or local hormone treatment, will it help her in solving her sexual dysfunction? Dr.
Yes, systemic HRT only if it is associated with hypoestrogenic vasomotor symptoms like hot flushes, sweating, mood swings, etc. we can use. Otherwise, in case of dyspareunia, genitourinary changes, local hormonal applications, either in the form of rings, pellets, creams, can be used. So the side effects may be with the estrogen, thromboembolic complications, and when it is used along with the progesterone, the breast cancer risk and cardiovascular risk is there. And in testosterones, there is a risk of increased risk of breast cancer and hepatic side effects and deepening of voice, acne, etc.
Yes. Dr. Sobani, so we now all this we have already discussed in different ways about the various causes of FSD. Quickly, can you just in a nutshell say what are the causes of female sexual dysfunction now?
So causes are non-organic, social, cultural, and psychological. In organic, there could be developmental, medical, surgical, drugs, ignorance, inadequate knowledge. There are myths and misconceptions, unreasonable and unrealistic expectations, and day-to-day stress, lack of time, exhaustion, lack of communication, performance anxiety, negative attitude, body image problem, disturbed interpersonal relationship, and male sexual dysfunctions.
Very nice. So these are various things. That's why, Dr. Prasanna, why should we treat this sexual dysfunction? What are the effects of sexual dysfunction?
Yeah, I would say that there are almost 8 effects we can say of sexual dysfunction. In order to not miss it, the first thing is that the self is very much annihilated or obliterated, and there is damage to the sexual self-esteem. Second thing is that the atrophy of the body disuse. There is a sexual dysfunction. The female doesn't use her sexual anatomy, and that can lead to disuse, atrophy. Third thing is the body systemic disorders, right from the big three, I would say the cholesterol, diabetes, and the hypertension. They affect the body, and in a reciprocal way. Fourth thing is the stress. Doctors do ask everything related to the bowel, bladder, appetite, sleep, but nobody asks for what about your sex? Are you happy in your bed? So sometimes the sexual problem can be cause of the stress, which can lead to many other disorders. Then I would say that the secondary emotions are the woman is frustrated because she is sexually frustrated. The woman is depressed because she is sexually depressed. And this is what we are supposed to treat. Now, this becomes the effect on herself. Now, the effect also gets extrapolated or transferred to her, I would say, sexual partner, whether and here I would say whether the girl, we should always keep in mind that all what we are talking is also applicable to the homosexual and lesbian girl. So whether the lesbian or homosexual passive active partner or the husband or live-in, he or she would get frustrated. And as you have rightly said, madam, that many sexual problems can lead to infertility and non-consummation, which affects the entire family, and especially the brunt is always being thrown on the girl or the woman, and she suffers a lot from her in-laws. The relationship gets disturbed, and finally, I would say that the overall the woman finds herself to be very powerless. She cannot do anything. There is an element of uncertainty, and there is an element of deprivation and a maladaptation, and this is what actually we should address. So this is what I have been seeing in my clinic and treating as per the requirement.
That's why it's very important to treat females, especially if she comes and complains about that. And it is your duty also to detect the problem in her and help her to have a good quality of life. Yes. And Dr. Nilima, in brief, the history taking, we have already discussed quite a few things, but in particular in history taking, what are the things that you concentrate on?
Like I said before, I concentrate on taking history, the medical history, what kind of medication they are on, to identify any kind of medical problems that may be affecting their sexual function, their relationship history, an effect of any the sexual function on the relationship, and effect of the relationship on the sexual function. Also, the effect of children. So children can have an impact on the sexual interaction and the relationship of the partners. So exploring that aspect is also important. And yes, talking about their personal beliefs and understandings about their sexual history and their sexual interactions. Like Dr. Prasanna said, the beliefs about how their sexuality is expressed at different ages in their life. Whether a pregnant woman should have sex or not, should she have sex after she's delivered, should a menopausal woman have sex or not, as you get older, if you've got grandchildren in the house, should the couple, I mean, we see this so often in my clinic where, when the grandparents come to visit, they are automatically made to sleep in, in a place where there is no privacy, or grandparents will look after the grandchildren. So grandchildren will go and sleep with the grandparents. So eliciting this history of privacy within the relationship is also important.
Yeah, very, very correct and very nice points you have brought out. And the other important thing is about the sexual or coital history. Just to get into the phases, whether she has desire, whether there is arousal, whether there is problem with the penetration, whether she is enjoying her orgasm. So that will pinpoint where exactly is the problem so that it becomes easier. And then the other history.
We have to take this history separately and together, because many times women do not open up in front of their husbands because they feel like they're criticizing them.
Very correct. Very true. Dr. Basuki, what about this gynecological examination? How does it help? What are the advantages of gynecological examination and these causes of gynecological causes of female sexual dysfunction?
With gynecological examination, by inspecting the vulva, doing a bimanual as well as monomanual examination and speculum examination, we can rule out many, that is infections, if any, and vaginismus, hypoestrogenic state, where the skin color and texture will be low, and the pubic hair amount will be low, and doing monomanual in case of vaginismus and dyspareunia by not keeping the hand over the abdomen. So we can palpate the rectovaginal surface and palpate the levator ani, and bimanual examination to rule out corneal tenderness, and in rectovaginal space we have to do rectovaginal examination also. And by doing speculum examination, we can rule out the infections. So the pH.
So this gynec examination, one thing you have to know that it is both therapeutic and also it is the examination, and also it has got a therapeutic effect. You can teach her, you can know where exactly it is, just remove myths and misconceptions, and for the body journals, explain her genitalia and the sexual functioning, all these things. It has got both these effects, diagnostic as well as therapeutic effect. So gynec examination is very important in such conditions. Dr. Sobani, whether there are any lab studies or what exactly you can test in such conditions?
For me,
Madam, sorry for the interruption. So,
I know that another 5 minutes.
5 more minutes. Yeah, okay.
We'll finish that, almost coming to the end.
For me, the sexual health and general health are equivalent. So whenever the patient comes with a sexual health problem, I have to examine the patient from fitness and normal point of view. Obviously, we are doing hormonal study like thyroid, testosterone, DHEA, estradiol, LH, FH, prolactin. This is what we are doing. But besides this, very important is your hemoglobin, blood sugar, then your renal, hepatic, and thyroid function. I'll just share in brief one case. I had a couple who were in Dubai. Lady was 32 and the husband was 42. They were come for a holiday here and they came to me and they had low sexual desire or no desire. When I asked them, they said they are not doing sex for 5 years. When I went for checkup, they had said that I found that the male kidney was totally peanut size, and the urologist and they told me that he has to go for kidney transplant, and the patient was done, kidney transplant was done. So they were shocked that how could a doctor diagnose a kidney problem? It is just because of no desire for sex for 3 years at the age of 42, being with a wife of 32. So we need to take things seriously and get the patient's examination in thoroughly.
Yeah. Dr. Prasanna, quickly about what medicines are available to give orally in case of FS, please.
Yeah, quickly I would say, and madam, you are conducting it really very nicely. Basically in PCOD and metabolic syndrome, in my clinic, I have been using in women drugs like metformin, then myoinositol, then spironolactone, ciproterone, and flutamide. I also use B12, vitamin D, simple aspirin and clopidogrel and arginine, which act on the endothelial and the vasa vasorum, vasa nervosum. And we should know that the arousal, just like an impotency or erectile dysfunction syndrome, is a red signal for the cardiac disorders in the men. Maybe in the arousal sexual syndrome could be a sort of what I can say, the red signal for the cardiac disease in the women. Sometimes I have used cabergoline, Inderal, And of course, as I said, the origin of the libido is in the nucleus accumbens and the hypothalamus and the limbic system, for which dopamine agonists are being used, but I have not used. And then there are many drugs like flibanserin which are coming on the market. There is the thing called as vasointestinal polypeptide, the prostaglandins, and even sildenafil is also used in human, but I have not used.
Okay. Certain things are available and few drugs are not available. Quickly, Dr. Neelima, are there any medicines which can be used locally?
Locally, I encourage especially women going through menopause or even post during the lactation period, if they have difficulty with vaginal dryness, encourage them to use local lubricants, water-based lubricants. If there is an infection, treat the infection. Encourage them, if they are menopausal, we can use vaginal estrogens. Vaginal estrogens are available in a multitude of preparations. They can be creams, tablets, pessaries, rings. Vaginal sildenafil also has been tried. Around the clitoris, we can use nitriga gel, Visna gels. These have been used. I try to avoid using local anesthetics because sometimes when they rub up on the penis.
Yeah, that's very nice. Dr. Vasuki, does counseling help? What's the importance of counseling in FSB?
Yes, definitely counseling helps, madam. Even after these much years of work in female sexual dysfunction, we mainly focus our thing in counseling. In many cases, sexual ignorance may be a cause of sexual dysfunction. So sex education, the anatomy, the physiology of sex and everything, and to remove myths and misconceptions and focused suggestions like sensitive focus exercises, Kegels exercises, and relationship problems we can solve with counseling. So much can be done with counseling.
Yes, counseling is very important. So, Dr. Sobani, what are the other methods of treatment recently which are coming up in cosmetology and gynec cosmetology and various new methods which are coming up to treat some of these female sexual dysfunction? Can you just at least enumerate a few of the newer developments, Dr. Sobani?
The basic is pelvic floor repair surgery. And then we put them on Kegel exercises, then vaginal rejuvenation like tightening, laser treatment, then Botox injection to relieve the muscle spasm. And the most common thing today is PRP. This is to rejuvenate vaginal walls, clitoris, pelvic floor muscle, labia, and G spot and O spot. Yeah. And then there is a sex toys which induce clitoral stimulation.
Yes.
So these are nutshell the local latest treatment happening. The PRP is the most recent one which has been.
Because some of these women who are enlightened or who go through this net and study so many things, they can come and ask you, these are all the developments are you doing? So some of these are available, and if you can provide them with that, certainly that can be used. Dr. Prasanna, sometimes you may not find anything. If no etiology is discovered, then how do you treat them, or what advice you can give them?
Yeah, so I would say basically that we have to be like an archaeologist. We should first rule out everything organic. Then only we can say that it is psychosexual and social. Second thing is that it could be just a feigning, malingering, deception, or a pretense by a lady just to get away with the man. It could be a somatization, what Freud had told as regards hysteria, and it could be just an attention-seeking device and or part of a psychiatric disorder. Say, for example, I had a woman who had a sexual delusions, and the role of psychiatrist was more important. And finally, I would say, as Eric Berne and Thomas Harris have told, that sometimes the woman can play games with her partner where she actually doesn't want intimacy at all with her partner, and she is using sex as a strategy or as a weapon to keep away, and that is called as a sexual uproar game. So this is what I happen to see in my clinic.
So in such conditions, at least provide them education, so you can enhance the stimulation and tell them the proper say how to go about a proper sexual, because many are ignorant or inadequate knowledge. Yes. And this itself will solve so many of their problems. So they have to have distraction techniques and also this non-coital behaviors. As you were describing earlier, sex is not just about erection, penetration, and ejaculation. There are various, all the other things. the road to the destination, that is also very important. So let they have to minimize dyspareunia in whatever way. So ultimately, you should never forget the partner, because in whole of female sexual dysfunction, a female sexual dysfunction can lead to male sexual dysfunction, or a male sexual dysfunction can also lead to female sexual dysfunction. So it is couple as a unit, which is very important. You should also understand the male point of view of FSD. So male sexuality is equally important when you are taking history. So the male sexual dysfunction, so many times, sometimes a patient will come and I have got erectile dysfunction, I am unable to penetrate and I cannot do it. But if you ask him to bring the wife, and you just see the wife will be suffering from vaginismus. So that can lead to secondary erectile dysfunction. So many times couple will not understand. And the woman will come and tell, he has got the problem, I don't have any problem, you just treat him. But when you examine her, she will be suffering from vaginismus. You have to ensure that the partner is healthy, ensure remove other stresses in the family. So ultimately, what the women's sexual problems may be viewed as women not getting what they want. That is the main thing. So what women want? The women want consensual, mutually satisfying sex. Women want relationships. Women want self-love. They want time. Women want sexual health and liberation. So that is what it is, and what the woman should understand, what the doctor should understand. You should avoid them going to quacks when we are there to treat them, the qualified people. So they should not be trapped by the local quacks. So a big thank you to all of you, to Astinar and to all my esteemed panelists for their wonderful interaction. And really, I'm so happy, and they all interacted so well and gave a lot of input. I'm sure everyone will go home with good knowledge of sexual health, and at least little awareness, so that they can make sexual history part of overall history. And if they cannot handle, at least they can refer the cases to proper specialists. Thank you very much. Thank you all.
Madam Bakmini, one minute. Thank you for a wonderful panel discussion. One thing, in the unconsummated marriage, when the female vaginismus may be the cause, but usually male partner has been blamed. Especially in sexual dysfunction, male partner is often blamed. Infertility, women partner is often blamed by the society. That is very important. And in the individual, female partner does not know that she is having problem, and male partner often has been blamed. And in the history takings, sexual abuse in the childhood, that's also very important. And one more thing is the importance of foreplay in arousal disorder, and afterplay is also very important. That is also, we have to ask detail whether there is foreplay, because women arousal is a little later, and the foreplay plays a very important role. Thank you very much.
Thank you for your wonderful inputs, and you are very correct about this importance of foreplay as well as the afterplay, because sometimes with the early ejaculation, premature ejaculation, the woman is still in the pre-orgasmic phase, and the man does not know that there can be afterplay, which the woman can have arousal or orgasm even after his ejaculation. Because usually the men stops after the ejaculation, and no more stimulation. So woman feels frustrated, and she feels as though she is left in the half. So that is what it is. And you are very correct that the importance of afterplay also has to be told to the man.
Thank you.
Thank you, madam. Thank you. Over to Dr. Pai. Pai, sir, you introduce the second moderator.
Yeah. A very good evening to all of you. Thank you, Dr. Bhumesh, and the organizing chairpersons and the organizing team of Indian Association of the Study of STD and AIDS, and this Astinar-6 academic session. It gives me great pleasure and a privilege to be a part of this academic meeting, Astinar-6 academic session. In fact, I am thankful to you, to the organizing committee and the scientific committee for inviting me to be a part of this Astinar-6 and to chair the session. It should have session 1, the panel discussion. So we have a very eminent panelist, and Dr. G. Venkatramana will be the moderator for this session. And it's a great pleasure to introduce Dr. Venkatramana to moderate this session. Dr. Venkatramana was a retired professor and head the department of Osmania Medical College, Hyderabad. And in fact, I'm very impressed by his the CV, which is running into several achievements. But the salient aspects is he has an impressive 576 presentations on in various international, national forums, and 19 publications documenting his scientific work, and has several honors, awards, and appreciations on his name. Especially, I would like to highlight the WHO Fellowship on twice, that is in 1990 and 2009, on STDs and AIDS. He was a council member of the Asia Oceania Federation of Sexology. The important honor that has been conferred on him is the Golden Lamp Award, which is the highest honor in India in the field of Indian sexology. He has been also awarded the Outstanding Service Award in Sexology at the SexCon 2014, which was held in Mumbai. And he has been the president of Indian Andros Society, also the associate editor of the Journal of Sex and Marital Therapy, and the vice president on Council of Sex Education, Parenthood International, and the South Zone representative of ISSTD and AIDS. Especially areas of interest are sexology, STDs, HIV, and AIDS. So with this, I request Dr. Venkatramana to take over the proceedings and initiate the session panel 1 and start the proceedings. So thank you very much.
I request all the except the moderator and panel members, I request all please keep it in a mute form. Over to Venkatramana, sir.
Thank you very much, sir. Thank you for your kind, sexy introduction. Now I will start my presentation. My dear friends, as you all know that each and every living organism in this universe is bestowed with the basic instinct called sexual union. This basic instinct is expressed for procreational purposes in the lower animals, whereas we human beings are expressing this for recreational purposes. When we are expressing this for recreational purposes, two types of problems crops in, one being sexual infections, other being sexual dysfunctions. For today, we take up sexual dysfunctions as a topic for discussion. To understand these sexual dysfunctions, I just simply divided scenario before World War II, scenario after World War II. Before World War II, everything was only two types. All female sexual problems are called frigidity. All male sexual problems are called impotency. After World War II, observational studies, epidemiological studies, psychoanalytic studies, evidence-based lab studies came into picture. As a result of this, the hard work of Henry Havelock Ellis, Sigmund Freud, Kinsey is a very big man. He has conducted a huge epidemiological study and he has contributed a lot to the sexology. And the real champions, Masters and Johnson, who conducted in the laboratory using the human volunteers, using these gadgets, and they could came out that human sexual response cycle will be starts with the excitement, then reaches to plateau and goes to orgasm, then comes back to the normalcy called resolution. To this is the model they used, and for male this is added by Helen Singer Kaplan, who contributed that desire should be there, then only total response cycle will be starting. That's why she added desire component for this. Since then, we all the sexologists around the globe are using this DOR model for male sexual dysfunctions, namely desire, erection, ejaculation, orgasm, and resolution. So anybody with this can suffer with desire dysfunctions like hypoactive sexual desire, hyperactive sexual desire, sexual aversion. In the case of erection, erectile dysfunction. Same way ejaculation, premature ejaculation, retrograde ejaculation, retarded ejaculation. For orgasm, anorgasmia, lack of orgasm. For resolution, priapism. These are all the dysfunctions they will give it. Anybody can suffer. As a result of these dysfunctions, more relationship problems, poor general happiness, low self-esteem, low physical satisfaction, low emotional satisfaction, all put together making diminished quality of life will occur. As rightly pointed out by the earlier speaker, Padmini, the DSM-5 clearly shows that all these disinfections should be there for more than 6 months and should occur at least from 75 to 100% episode. Then only it should be called as a dysfunction. So sexuality is a complex process coordinated by the neurological, vascular, and endocrine. So nervous system.
Sir, excuse me, sir, you didn't share your screen, sir.
I'm sharing, ma.
No.
No, sir, not shared.
You didn't share, sir.
Right, I'm sharing by here. Here it is coming.
No, no.
No,
Now?
no,
No,
Now?
no,
No,
it is
sir.
not.
No.
Even now?
No.
Now?
No. We are seeing you only. Not your PPT.
Now?
We are seeing your only sexy face, not your PPT.
How come?
This is a sexual humor, is it?
Yeah.
Yes, that should be there. That should be there. Share my screen.
No, no problem, sir. You introduce your
Yeah.
panelists and you ask the question. That is enough.
Because of
Some technical problems. Okay, carry on. No
Yes,
problem.
yes,
Just
yes.
you introduce.
problem is there, but
Or you can share to.
I'll share. Wait.
Okay.
I'll share.
Yeah. Now it has come.
Now, okay.
Yeah.
We are seeing.
Yes.
Now we are seeing your sexy PPT.
Yes, thank you. So now you know pretty well it is complicated by the neurological, endocrinal, and vascular, as well as incorporates the family, societal and religious beliefs and interpersonal relationships also. So for anybody to have good sex, one should have intact libido and one should have favorable hormonal effects. One should have adequate vascular activity. One should have intact autonomic or somatic nerves, as well as intact erectile tissue integrity. So for male purpose, so one should get a desire. That desire can come through fantasy, seeing, touching, reading, and listening. Through these special senses, the desire will be generated in the mind, that will be conducted through the parasympathetic nervous system to the genitalia penis. Then vascular gushing will occur because of the release of nitric oxide in the penile corporeal tissue, as a result of which the person gets erection, and that becomes because of the vasodilatation, and that can be utilized for masturbation as for sexual intercourse. So breakdown of any of these leads to sexual dysfunctions. If you look into the prevalences, around 1/3 of the men, 31% of the male people are suffering with these dysfunctions. And all the human sexual problems, particularly in males, not only in males, even females also, can be classified into categorized into 6 categories, namely sexual concerns. That is, myths and misconceptions, adjustment problems, dysfunctions, orientation issues, gender identity issues, and paraphilias. Concerns, myths and misconceptions, adjustment problems, that is interpersonal problems, sexual dysfunctions like erection, ejaculation, orgasm, and orientation problems, homosexual, heterosexual, bisexual, pansexual, asexual, and gender identity. Some people will feel that I am a male, but trapped in a female body. I am a female trapped in a male body. So this type of psychological attitude will be there. Paraphilias, they will get stimulated by seeing by others activities like what you call peeping toms, necrophilia, and even many other small problems are there. For this, the total scenario treatment modality will be counseling and education, clearing myths and misconceptions, individual couple counseling, behavioral therapy, treatment of genital infections, hormone replacement therapy, drugs oral and local, vacuum device, penile vascular surgery, penile implant surgeries. So these are all the things. Now coming to the real crux of the problem, case-based panel discussion. Now for this, I invite the panelists, the senior most member, Professor Dr. S. Murugan, ex-professor in Department of STD and HIV DVL, consultant sexologist and STD specialist at SIFA Hospital, Tirunelveli, and he is presently president of IASTD Association, and he is executive member CSCPI, has delivered many orations and contributed many chapters and published many books, and he is a PG examiner and inspector also for my MCI, and his areas of interest is STDs, HIV and sexology. So I welcome you, sir.
Thank you.
Next, I welcome Professor Dr. B. Uday Kumar, retired Additional Director of Medical Education, presently working as Professor of DVL, SVS Medical College, Mahbubnagar. He is also a very good academician and a PG examiner and inspector. Welcome you, Uday. Then comes the Prince of Hyderabad, Dr. Sai Krishna Kotla. He is a consultant in Yashoda Hospital, and he is a life member of IADVL, and he is a principal investigator in clinical trials of psoriasis and acne. And he was a past general secretary of ISDO Telangana. I welcome you, Sai.
Thank you, sir.
Then comes the BS Praveen.
Praveen is not joining, sir.
Okay, thank you.
Because of some work, na? So you take care of his questions.
Yeah. Now the case studies are: a male patient of 35 years came to your clinic saying that, doctor, of late I am not getting standard erections, not able to complete the sexual intercourse. My wife is getting irritated and making derogatory comments. Please help me what to do now. This is one scenario. The second one is, couple of 5 years of married life came to me for consultation. Wife says he is unable to perform in the bed. The third scenario, young IT couple of 3 years of married life consulted her doctor for kids. On examination, his semen analysis is within normal limits. 30 million is the count, 50% is the motility, 70% is the morphology. Whereas a wife's ultrasound shows follicular study has confirmed the release of the ova. The fourth scenario is, doctor, I am 32, married, maintaining a girlfriend also. I get excellent erections and happy performance with my girlfriend, but not that strong, not that happy performance with wife. Why? Now tell me how to proceed. Sai, can you tell me what to do now?
Sir, first, in all the case scenarios, history is important, sir. History taking.
Excellent. Excellent.
All of them, medical history, psychosocial history, and sexual history has to be taken.
Why we are unable to take the history? What are the constant obstacles for taking history?
See, sometimes it is the time constraint. In the busy practice, we are not able to give sufficient time. So just examination we want to do. Or physicians discomfort with the topic, because some physicians are not very well versed with these topics, and they personally feel discomfort when they are discussing this topic.
Excellent.
And then lack of training in medical colleges, because the approach to these things, the inhibitions have to be removed.
Because of, yes, excellently brought out. Because of this only, the quacks are thriving. We, the qualified doctors, are not studying sexology in medical colleges, in medical curriculum. As a result, we are not confident enough. That's why we are not dealing. Whereas quacks are taken up this and they are dealing with this and they are enjoying the bread. Now, what are the prerequisites of the doctor for taking these sexual problems?
You see, they should have a basic, not only they should have a knowledge behind this medical,
Yes.
not only medical knowledge, they should have this guidelines for asking questions,
Yes.
what right questions.
Yes.
They
Yes.
should have an open mind. They should not be judgmental.
Yes.
So once they are biased
Excellent.
and then they think that is always an sexually transmitted disease they are discussing, then it is wrong, because sexual dysfunction is separate from sexual transmitted diseases. And then it should be they should be ready to investigate the patient. They should have some empathy and approach towards the patient, because
Yes,
that
exactly.
basic
So
human
the
empathy.
doctor should be interested, should be open-minded.
One more thing is the patient, we have to get a rapport. First, invite the patient, talk to them normally, some other thing and friendly. Then he has to develop some trust.
That is there in the next slide. That is there. That is there. Okay. So this is the dermatology OP which we see every day. So in front of those patients, if you ask, tell me about his history, tell me about what's happening to your sex, no patient will open up. So for this, absolute privacy and confidentiality is needed. As rightly said by our Morgan sir, rapport building is needed. That's why it is a little bit different. STD clinics and sexology clinics, they need privacy and confidentiality, and a rapport building is must. Excellent, Sai. Excellent. So when we provide privacy, it will be one-to-one or one-to couple, not before all the people. So like this, we will be taking present history, past history, including genital injuries and genital surgeries, personal history, including psychosexual, and past history of molestations, genital trauma, present sexual history, relationship history, and drug history. So all these things will be taking. So if the patient is opening up, fine, but that will be very little minimal people. Majority of times, we doctors have to open up and start the discussion, saying that, tell me, Mr. XYZ, how are you? How is the sexual life? Are you in relationship? Are you sexually active? How the things are going on? Wow, tell me any problem in your sexual personal life. Are you directly homosexual or heterosexual or bisexual? Are any sexual concerns are there? So like that, once you initiate the dialogue, then the patient will open up and he will reveal his real history. If we are working in an institute, big institute, sexology institute, there the things are different. There the questionnaires will be administered.
Yes.
The patient, before seeing the consultant, outside the people will give the questionnaire to them. They will fill it up. International Index of Erectile Dysfunction, Sexual Encounter Profile, Global Assessment Questionnaires, and PAIDs, and CRO questionnaires, Erectile Dysfunction Edit questionnaires. So this is not in a case of a individual small clinics and hospitals. If you are working in institute, this is the pattern, right? So in the history taking, will be going for present complaint and duration. History of present illness will be explaining that how long the ED problem is, how frequently you have intercourse currently, are you getting firm erections, are you getting early morning erections, are you doing have any other that will be inquiring. At the same time, we have to inquire about this problem is primary or secondary. That is, it is there from the beginning of sexual life, or it has been complex. At the same time, you have to inquire whether it is global or situational. The fourth case which I focus will fall into
the remaining all you keep it in
okay, sir. Fourth case will fall into this category of situational erectile dysfunction. The fellow who is maintaining girlfriend is happy with the girlfriend, not with the wife. At the same time, we have to inquire about physiological, mechanical, and psychological factors also. At the same time, we should not forget today, because of the LGBT activity is very high around the globe, we have to inquire about sexual preferences. Homosexual, heterosexual, bisexual, pansexual, and asexual. These are all the classifications. So establishment of patient sexual orientation is necessary for appropriate evaluation and management. So these are all the various sexual orientations will occur. Today it's very rampant now. Then we had to inquire about past history of diabetes, hypertension, liver problem, kidney problem, past STDs, HIV, tuberculosis, past sexual encounters, premarital, postmarital, sexual abuse, insults, and what you call punishments, all these things we have to inquire. Then personal history we have to inquire about the alcohol, smoking, drug, diet, sleep, and the psychological history of anxiety, depression, etc. We have to inquire about all these things. Prior sexual experiences, if they are encouraging, that will have a positive effect on the sexual life. If they are punished, that will have a negative on the sexual life. His stories, her stories, injuries, punishments, all these things will have either positive or negative effect on the present complaint. That's why we have to evaluate this. We have to take the proper history, cheating of the partners. All these things one has to inquire in the history taking. As a result of this, the interpersonal problems like loss of trust on the partner. Husband won't believe, won't trust the wife, or wife won't trust the husband. Poor communication between them, anger and resentment, conflicting sexual expectations, lack of respect to each other, lack of love between the couple, and the interaction of all these things is going to spoil the sexual relationship between the couple. So all these are type of problems, whether man beating, domestic violence, sexual violence, all leads to so near yet so far, they will be under one room, but no way in having any sexual intercourse. Then we had today, presently, our lifestyle is such that we have to inquire about food habits. Everybody, including me and you, everybody are consuming lot of saturated fatty acid junk foods, which is causing lot of endothelial dysfunctions and vascular problems. See, junk foods we are consuming, aerated drinks we are consuming, as a result of which obesity, metabolic syndrome, hypercholesteremia, endothelial dysfunction leading to sexual problems. And today's cultural enemy is substance abuse, alcohol and smoking. These two are enemies. If you look at this slide, the fellow, once he gulps the alcohol, the girl looks tall and pretty. Once the alcohol effect is over, she looks clumpy. So this how alcohol affects the make it, but take it away the action. And there is a saying, जब आप देश की शराब पीते हो, मुझे पारू कहते हो. जब आप देश की शराब पीते हो, मुझे पारू कहते हो. जब आप स्कॉच पी रहे हो, मुझे डार्लिंग कहते हो. आज क्या पिया है, मुझे शैतान कह रहा है. Then that fellow is telling, आज मैं होश में हूं, इसीलिए शैतान लग रहा है. So that is the effect of alcohol that will have on this sexual response. Smoking, another fundamental culprit, the vasoconstrictor effect, and family upbringing, that is interpersonal upbringings, family beliefs, human life values, respect, personal respects, and another important present day lifestyle is sleep patterns. Today, because of the night working, day working, working up to 2 o'clock, starts working from early morning onwards, and early morning flights, all these things are making disturbed sleep. This disturbed sleep will decrease the sexual hormones, will affect the diurnal rhythm, will decrease the sexual hormones that will affect the sexual intercourse. At the same time, we have to inquire about comorbid conditions like diabetes, hypertension, hypercholesteremia, metabolic syndrome, prolactinemias, renal failure, liver failures, etc. At the same time, today our patients are believing that for every ill, there is a pill. For every ill, there is a pill. But don't forget, all these pills will have drug-to-drug interactions and negative effect on the sexual cycle, particularly painkillers, opiates, antihistamines, muscle relaxants, anti-cancer drugs, Parkinsonism drugs, antidepressants, diuretics, and antihypertensives. We dermatologists, we particularly using left and right our steroids. They are fundamental culprits of decreasing the Leydig cell testosterone production. Ketoconazole, that again decreases the testosterone production. Ethanol, alcohol decreases the testosterone production. Spironolactone, flutamide, estrogens, progesterones, all these things are having negative effect on the sexual life. That's why we had to inquire about the drug histories. At the same time, systemic diseases. And today, endocrinal disruptors are the another fundamental culprits, like using our scents, room aerosols, room fresheners, and the phthalates, plasticizers, pesticides. Today we are consuming all the way fruits, vegetables are all ridden with pesticides, which is causing a lot of hormonal disturbance. And all pesticides and plasticizers are pro-estrogens, that having a very negative effect on the male sexual cycle. That we should not forget. We have to inquire about this. All aerosols and injuries and operations on the perineum, compressions. See the perineal compression, injuries in the childhood. This type of activities will have perineal compression and injury and compromising blood supply to the penis and pelvics. Bulgur injuries, perineal surgeries, prostatectomies, retroperineal surgeries, sympathectomies, colostomies, all these things one has to inquire about and in the history taking. At the same time, we should not forget about taking history from the spouse, because from her angle also one has to listen, then only the history will be complete. That we should not forget. So talk to her, then talk both together. That is very important, because which is leading to which will be come to a conclusion after listening them. Then Sai, after history taking, what we have to do?
Sir, next comes a physical examination, sir. There
Yes.
are basically eliciting the reflexes, basic reflexes.
Excellent.
And then examination of the body. After examination, physical examination, you can go for the investigations.
Excellent.
Especially diabetes, hypertension, hyperlipidemia. These
Yes.
are the common causes for medical causes for this one, sir.
In the earlier studies, earlier slides we studied neurological, vascular, endocrinal. So we have to search for secondary sexual characteristics. We have to search for peripheral pulse examination, cremastic reflex, neurological exclusive assessment, respiratory abdominal examination, local genital and rectal examination because of the any STD, Sharp-Frenum or Peyronie's disease. One has to examine this. Then go for neurological, cardiovascular, organic causes, genital examination, bulbocavernous reflex, hydrocele, hernias, all the penile curvatures, everything we have to assess. Then after coming to this, then don't forget to do perrectal examination in males, because prostatic seminal vesicular problems do affect the sexual cycle. So always do perrectal examination to assess the prostate health and seminal vesicular health. So perrectal examination is very, very crucial in coming to a conclusion in male related exam. Then as rightly said by our Dr. Sai, laboratory investigations. Now we will go to our stalwart, Dr. Murugan sir.
Regarding the investigation, I used to go by history and examination and age, and whether the patient is a primary or secondary. All these things I have to consider.
Yes, sir.
And if it is usually diabetes has to be ruled out first and foremost in all cases. So the diabetes is the most common culprit. So diabetes and all the other things, that is a complete hemogram, ESR, the hepatic profile, kidney disease, RFT, all these things will be contributing in the sexual failure. And hormonal thing, and usually I discourage seminal examination, hormone examination unless indicated. For example, if it is an obvious hypogonadism, I will go for hormonal examination. Otherwise, I will not go for hormone examination. Likewise, if the seminal examination is indicated only in the case of infertility, some people directly, because what is the reason is, if you point out some mistake in the that is seminal examination, it will do more harm to the patient and his psychic and personal esteem. And also likewise hormone also, and that is only, it is indicated only in the when we are seeing high secondary sexual character or hormone or some other thing is there, then we have to go for hormone exam. Otherwise everything is there. If, for example, early morning erection is there, secondary sexual character is there, hormone examination is not necessary. And
all investigations are case-to-case based.
Yes, case to case based, and according to the age, how many years, all these things I bear.
So special investigations like duplex color Doppler, again case-to-case based, and Regiscan case-to-case based. And of late, a non-invasive technique has come. I am using this called endopat test. This endopat test this is penile angiogram, very localized, focused, there is a vascular abnormality, then only done. This endopat test is very, very useful, a bedside procedure where within 15 minutes, you can assess the endothelial health of the individual. This endopat test. Now comes after investigations, we will be coming to a conclusion whether that particular patient is having a organic problem or psychological problem, but most of the times it will be a mixed problem, because even organic problems will have psychological overlay on that. It's a mixed problem. So now, what are all the issues that come into psychogenic issues, sir? Murugan, sir.
Psychogenic, from the beginning, I have to examine the patient. If the patient is a young individual and sometimes came for a sexual dysfunction or erectile dysfunction, misconception and myths and misconception plays an important role. Yes. And so that is one thing I have to clear. What is the I have to identify regarding the size of the penis, masturbation, and semen is a precious thing. All these things makes the individual that he lost his semen or his penis is small, or obesity appears, the penis appears small. All these things we have to do. And one more thing is that is the previous failure. That is a previous failure. One failure leads to multiple failure, whether it is before marriage or after marriage. So what is the reason for this failure? That's also we have to analyze. So on that basis, only thing in the history or anything, we have to find out the basic cause for this sexual dysfunction. So their history and other things we will help. And after finding the basic, only we have to go for.
Coming to the organic, we have to assess for vascular cause, neurological cause, hormonal cause, or infection or tissue integrity of the penis.
Yes.
So after assessing this, once the person comes with the complaints of erectile dysfunction, all the 4 cases which I focused is a erectile dysfunction. They are suffering because of various reasons. One is a situational erectile dysfunction, one is a psychological erectile dysfunction, or 2 are organic erectile dysfunction. We'll be discussing that after the few slides. So when erectile dysfunction is diagnosed, the definition goes is like this: consistent or recurrent inability to attain or to maintain the penile erection sufficient for sexual performance. So this is consistent inability to maintain, to get erection and to maintain erection to complete the sexual intercourse. If you look into the statistics are clearly showing various studies around the globe, showing that 30% to 70% based on the cohorts. So whereas in hypertension clinics, 67% are suffering with erectile dysfunction. Here in coronary heart disease patients, 70%, diabetes 78%, in psychiatric illnesses 70%. All put together, 42% of men visiting various clinics are suffering with erectile dysfunction. So here, this is published in the International Archives of Internal Medicine way back 2016, showing that around 50% people suffering with erectile dysfunction. Here again, 40 to 70 years old suffering with 30% dysfunction. Here a Singapore-based study where it is showing around 30% dysfunction. Like this, various studies are there. 15% in Brazil, 34% in Japan, 22% in Malaysia. Like this, all, even these are the age group. The more the age, the more the senior is, the more is the percentage of prevalence of erectile dysfunction. This is the benchmark study called the Massachusetts Male Aging Study, where the cohorts are very huge in number, 1,290 cohorts, 90 patients they studied. They could come to conclusion that in 2005, they could see around 15 million of patients affected with men will be suffering with erectile dysfunction worldwide, And they projected by 2025, 300 million men will suffer with erectile dysfunctions. So you can see the huge opportunities to serve these needy people. So based upon the age, around 40 years, 40%, and when the person becomes 70 years age, around 67% of the people do suffer with erectile dysfunctions. So again, once again, reiterating the definition, consistent or recurrent inability to attain or to maintain a erection sufficient for sexual performance. So on average, it is 20 to 30% we people who are suffering. And India is notoriously, because of huge population, and it got a dubious distinction saying that by 2030, it will be important capital of the world because of the huge diabetic population. And it is a diabetic capital of the world. As a result, 70% of diabetics do suffer with sexual problems. That's why it is got a dubious distinction of becoming the impotency capital of the world. So a lot of Indian studies do confirm that the erectile dysfunction is there in the human beings, in Indians. And this erectile dysfunction is clearly marked as a what you call surrogate marker for coronary peripheral cardiovascular disease because of the same endothelium that is there also. So erectile dysfunction is because of endothelial dysfunction. Endothelial dysfunction leads to coronary artery disease that leads to cardiac problems. That's why ED is equal to ED is equal to ED. Erectile dysfunction is equal to endothelial dysfunction is equal to early death. That's why it is a harbinger of the cardiac problems. Cardiac problems can be detected, can be tackled by the proper counseling and education, lifestyle changes at the level of erectile dysfunction itself. So the human being, particularly males, the penile artery diameter is 1 millimeter more than the coronary artery diameter. That's why around 2 to 3 years prior to the heart attacks, the fellow will develop penile attack. That is erectile dysfunction. So at the level of erectile dysfunction, if you are able to counsel them, educate them, and give the proper guidelines towards the lifestyle changes, we can prevent the future heart attacks, future coronary artery problems. So today flaccid penis is tomorrow's heart problems. So now treatment, we'll go to treatment, sir. Erectile dysfunctions. So in 1960s, only sex therapy and counseling was there. 17s, penile implants came and vacuum devices came. 1980s, penile injections came. The phenomenal sea change came in the management of sexual dysfunction. In 1998, the Pfizer's introduction of Viagra, sildenafil citrate, followed by 2000 Cialis and Levitra, that is tadalafil, and this avenafil recently added to this. And 2010, gene therapies and stem cell therapies came into the now in the phase 3 trials. Shortly they are going to come for a doctor's armamentarium to use for the needy, for the treatment of these needy patients. Now tell me, sir, what are the first line treatments for these people? Murugan sir, first line treatment.
So treatment, once again, I will plan according to the etiology, whether it is psychosocial, psychosexual, or organic, or combined, or due to comorbidities, all these things considering. So psychosexual, as we have to educate the patient and counsel the patient.
Yes, sir.
And we have to clear the myths and misconception.
Yes, sir.
Then if there is any obesity and metabolic disorder is the concern, we have to modify the lifestyle changes, and adequate sleep is necessary, relaxation is necessary. We have to come from the that is sexual and the stress of that work stress. All these things very important. Then only after ruling out all these things and after correction all these things, we have to go for oral medication. And if necessary, hormones. Once if there is we have to assess the hormonal levels, and if there is a real hormone deficiencies, then we have to put hormones. Yes, otherwise, oral medications, sildenafil citrate plays a very important role. We are having varieties of sildenafil citrate, low dose, demand dose, all these things are there. The low dose raises the confidence level. Demand dose makes the individual
That we'll take up shortly.
Okay.
So in lifestyle changes, have regular physical exercise. Now today, wherever we see the elevator, we see the escalator, we use it, we won't use the steps. As far as possible, try to use the steps. That is the only exercise we doctors can do. So that don't forget about the regular physical exercise. That is very much essential and that is needed for everybody. Eat healthy, balanced food. It should contain more proteins, less carbohydrates, less fats. More greeny, cruciferous green leafy vegetables. Have good quality of sleep because deprived sleep decreases the testosterone levels. Research has clearly shown 20 to 30% less testosterone if there is a insufficient or poor quality of sleep. Stop smoking. Reduce alcohol intake. If you stop, excellent, or else reduce it. 2 drinks for male, 1 drink for female is the highest quota. Should not exceed anything beyond that. Reduce the extra pounds. That is very important. Keep diabetes, hypertension, thyroid, lipid profiles under control. Have sex regularly. Because, my dear friends, the penis and vagina will work on the principle, use it or lose it. If you won't use it, you are losing it. Let the vagina or penis. So the more you use it, the more in a running state. That's have sex regularly. Research has clearly shown that when men who have sex regularly, they live longer because of the more cardiac health, not only sexual health. So more men have sex, the longer they live. That's why have sex regularly. Sexual inactivity results in the reversible reduction of the LH availability. That is, testosterone will come down. Men who enjoy better sex will have improved psychological well-being, quality of life improve. Risk of ED is inversely proportional to the frequency of sex. The more regular you have sex, less chances of getting ED. That's why you have to have sex regularly. Now comes the oral medications and SOS wherever needed, hormone replacement. Now again we'll go to Murugan sir. Tell me sir now about all these PDE5 inhibitors.
So PDE5 inhibitors increases the nitric acid availability in the tissue, thereby makes the erection for longer time. And we are having varieties of in armaments in our country itself. That is sildenafil citrate first available, tadalafil, avanafil, and vardenafil are also available. And tadalafil has a long acting and sildenafil is short acting comparatively. And sildenafil has you can be used mainly as a demand dose, and we can use up to 100 milligrams per day. And tadalafil we have low dose 5 milligram, 10 milligram, 20 milligrams available. The 5 milligram when we are giving daily dose, it definitely increases the confidence level of the individual, and he is having early morning erection, he will have a drive, so he will get a confidence. And when he is ready for sex, we can use the demand dose. And avanafil citrate really is a short acting, very quickly acting. So that is also some indication. So these are the drugs available in our country. And
what are side effects of these drugs?
Yes, sir.
Side effects of these drugs.
Yes, side effect we cannot give in the presence of especially hypertension, and the patient who took nitrates, it's a vasodilator, and the patient sometimes may have headache, tadalafil have myalgia, all these things are there, and we can change that. And especially in the presence of a heart problem, we have to be careful, and hypertension, we have to use restrictly. All these things are there.
So people are taking the nitrates are absolutely contraindicated. And when there is a cardiac failure, is again relative contraindication. Liver failure, relative contraindication. But once the patient uses this, usually 30% of patients will develop side effects like stuffy nose, dizziness, headache, flushing, nasal congestion. But there is a unique side effect of altered vision with the sildenafil, low backache with tadalafil, or rhinitis with vardenafil. These are unique side effects. So patient-centered approach is needed here because we have to inquire the patient lifestyle habits, his eating, sleeping habits. Then we have to give the proper medicine to him. For some people, tadalafil is needed. For some people, sildenafil is needed. Some people, avenafil is more than sufficient. So it's all case-to-case based because patient-centered approach is needed. So nitrates are the absolute contraindication. Pulmonary hypertension, another contraindication. Thromboembolism or coagulants are another contraindication.
Pulmonary hypertension, their indication, some people are using
low dose as a treatment.
As a treatment.
Yes. 30% of patients won't respond to these oral drugs. Have you observed, sir, in your practice?
Definitely. That is because when there is no desire, desire is necessary to initiate that. Only in the presence of desire, that drugs will act. So basically,
these are all the reasons why non-response will be there.
Yes, another thing is without correcting that basic cause, the drugs will not work. The patient may have misconception, low esteem, depression, so many other things. So that may be, we have to correctly diagnose it and we have to clear it. Then only the drugs will be helpful.
The patients will think that by I have taken the drug, it will do miracles. It will produce a erection. I will perform. It won't happen. Once the patient gets the erection, that erection can be prolonged by these drugs. So basically, the patient should get erection by himself, by fantasy, by kissing, by cajoling, by reading, by listening, by whatever method he is following, he has to get erection. With this drug, will prolong that erection. The drug per se, PDE5 inhibitors per se, they never initiate erection. They will prolong already existing erection. That we should know and we have to educate the patients. Otherwise, it will be a non-response.
So one more thing I want to tell before the drugs, some people will complain of the having difficulty in maintenance of erection or maintaining the erection. So that is because they are not able to complete the sex responsive cycle. So they will have the pressure performance, anxiety, or some other thing interfering with that. So they have to concentrate and they have to be how to overcome this. And also we have to explain how to complete the sexual response cycle.
The subsequent slides I will going to tell that.
Venkatraman sir.
I'm finishing.
Okay, then we have a quiz and Astinar.
These are all the reasons why the patients won't respond to these oral drugs. These are all the extensive reasons. Then comes the injections. Before going to injections, hormone replacement therapy for certain people where there is a definite testosterone deficiency is there, who have to give testosterone replacement. That is, there is an algorithm is there, flow charts are there, international guidelines are there. We have to follow these guidelines strictly because these drugs do have side effects. My dear friends, don't forget, all effective drugs will have side effects. So this is a very effective drug. It has to be given to the right patient in right dose after confirming the right diagnosis. Because of the time constraints, I am rushing the slides. So this is the flow chart where we have to give these drugs. Based on this, we have to give. So this is the way how we calculate the testosterone deficiency and we give these drugs. After giving these drugs, if the patient is not responding, then we will go for penile injections. These penile injections, they will produce more pain, more cavernous fibrosis. That's why we use very rarely. Most of the times for diagnostic purpose only we use it. And very rarely we use certain cases where there is an indication for case-to-case based only we use it. This testosterone can be given orally, injectably, gel and ointment, and even patches also can be given. Then comes this intracavernous injections. This is the prostaglandin E1 injection, Caverject. This is the costliest injection, and it has to be given into the penis. and there are guidelines for this, and I am not discussing because of the lack of time constraints. So same prostaglandin can be given intraurethral called muse. It is called mucosal urethral stimulated erection. This has to be given 125 micrograms, and who has to titrate it up to 250. Don't go beyond 1000 micrograms at any time of course, because it produces irritation and burning urination. So that's why we have to use this very cautiously, and it will produce pain and irritation. Then finally, the end result, if nothing is working out, the penile implants. The right side to me is the Shaw implant, that is 2-piece implant, and left side to me is the 3-piece implant, that is called inflated implant. So that's how the total treatment will be good. This is the latest treatments called topic gland, that is melanocortin activators, gene therapy. Today, now the scientists have come out that SM gene is located on the chromosome 6, and in few years, we'll get this into the doctor's armamentarium, gene transfer therapy. Then comes the latest stem cell therapies we are using now late. In PRP also we are using. Nitric acid polymers are also coming. Europeans are using this. Penile stent. Now all these days we heard about cardiac stents. Now the day is not far long. We are going to use penile stents, and we may be doing penile stent therapy also. These are all the various latest treatment modalities. This is the another modality which people are 4 to 6 doctors are using in India, called low intensity shock wave therapy to improve the vascular supply to the penis. Now coming to the cases again. The first case, Murugan sir, first case, 35-year male client. Doctor, of late I am not getting erections, not able to get complete sexual intercourse. My wife is irritated and making derogatory remarks. On evaluation, he is diabetic and hyperlipidemic and alcoholic. His HbA1c is 85%, FBS 203, PP 314. How do you manage, sir, this case?
So comorbidity has to be corrected first immediately.
Excellent.
So diabetes has to be controlled, and hyperlipidemia.
Yes, lot of comorbidities are there. It is an organic dysfunction. We have to control this, then we have to give treatment. The second case, couple of 5 years married life came to me for consultation. Wife says he is unable to perform in the bed. On evaluation, is obese, 112 kg weight with bilateral inguinal hernias. How do you manage this case, sir?
So obesity has to be controlled, and hernia has to be controlled. Otherwise, when he put pressure, and it will be giving trouble. So that's also very important.
Lifestyle modification is the fundamental treatment, first treatment for this fellow. In this case 3, young IT couple, 3 years married life, consulted doctor for kids. Semen analysis normal, ultrasound follicular study for her normal. Both sides parameter normal, but then why it is not happening?
So whether they are having time for consummation.
Yes, sir. That's
night duty, day duty, other thing. And another thing is the tube testing has not been done. Tubal patency, that's also very important.
Yes, sir. Case number 4. This is a very much is a situational, because happy with the girlfriend, not happy with the wife. This is a situational case. So like this, for case by case, we have to evaluate, and we have to take the proper history and assess the symptoms, give proper counseling, do proper therapy, so that people so apart, so aggressive can come together with your counseling and treatment, and we can save many families, and we can reduce the divorce rate in India. Today, Indian divorce rate is 15%. So we sexologists have to strive and see that families are maintained, relationships are strengthened by our counseling. Thank you. Thank you very much for your kind listening.
Thank you, sir. Thank you very much for your
panelists.
Thank you so much, sir. Yeah. Now we move on to the next part, the quiz for the PGs and the SR senior residents. Now I invite the today's quiz master, Dr. S.B. Kavita. So she needs no introduction. Now she is the associate professor and HOD from Government Medical College Hospital, Jagityal, and the former treasurer of TSIADL. And she has a lot of publications and interested in the various fields, genital dermatosis, all. Over to Dr. Kavita.
Thank you, sir. Viru, please display the rules for the quiz. Yeah, the instructions for today's quiz, there will be 14 MCQ questions and you should answer them all. Mark only one correct answer and the duration of time is only just 7 minutes. First two toppers will be selected from both PGs and senior residents and quiz master decision is final.
Request Viru to release the question key to the PGs and SRs.
Yes, sir. Please start it.
Started. Kavita, you invite the.
Meanwhile, I request Dr. Yes,
Yeah.
sir. Meanwhile, I request our Astinar star, Dr. S. Arun Kumar, who is a retired professor from Rajiv Gandhi Government General Hospital. He was formerly secretary for the Indian Association for the Study of Sexually Transmitted Diseases and AIDS in 2015 and 17. And to his credit, he has presented many papers and published many articles. So I request Arun Kumar sir to create awareness on the genital health. Over to you, sir.
Arun Kumar sir, are you there?
Yeah, sir is there.
Yeah.
Arun?
Arun Kumar sir. Sir, I think sir is not. Is there?
He's there. He was there.
Okay.
Arun Kumar,
So,
unmute yourself, Arun. Yes.
sir.
Any technical problem is unmute. You're not unmuting.
He is joining from UK, no? I
Yes,
think.
UK. He is
From
in
UK.
UK.
Yeah. Sir, Arun sir, you unmute yourself and speak. I think he has some technical issues. Now, the genital health, as we all know, the genital health is body health, mind, and sexual health. So, the genital health is as important as body and physical and mental health. That has to be initiated from the age of 6 years. And the cleaning habits, all previously Dr. Murugan sir has already illustrated. So, always you try to encourage from the pediatric age group the importance of the genital health. So we can tolerate all the tragedies, but we cannot. Nobody can tolerate the tragedy of bedroom. So let us sensitize more and more on the importance of genital health. With this, I request all the faculty members. Now you all are Astinar stars with this Astinar-6. I request we will share your Astinar star slide to create genital health. We request all of you to please share in your WhatsApp groups or Facebooks or Instagrams to sensitize and at least for 10 people and let them sensitize another 10 people. So now we are reaching towards the physical conference, which is going to be held in September 9th, 10th, 11th, myself and all Neta and all the team. So we request all the members of in this group, those who are interested, please say consent, give consent for the participation of this physical conference. We are happy to take your part as a faculty. So with this, I request over to Dr. S.B. Kavita for the results.
Arun Kumar sir is facing some technical issues, it seems. So sir is not able to join. I request Viru to display the key if 7 minutes is over.
No, ma'am, not yet done.
Okay. Meanwhile, I
15
request
minutes.
Murugan sir to at least create some awareness, sir, for 2 minutes.
I have to give an awareness. Yes, everybody knew the sexual health is very, very important. Free, uncompulsory coercion, the sexual health is very important. For the sexual health, one has to be free mind and love and affection should be there. And genital hygiene is very important. And people should know how to. Today we are having wonderful panel discussion on male and female sexual dysfunction. When we are listening to that, we will be able to have a good family, that is sexual health, and we have to promote this to everyone who needs it. So everyone needs it, especially it is not being taught in schools, not being taught in even curriculum in the medical college. So it is our duty to carry this message to all. So this way we can improve the sexual knowledge, genital hygiene knowledge, and there will be, we can have a normal and harmonious sexual life throughout our life. So it is a very important thing. We are having a lot of changes in lifestyle and other things. And at this juncture, what are the things we have to follow? What are the things we have to impart? How can we make it a successful one? That is very important. And we have good knowledge because of this panel discussion. And we will impart this knowledge to all the people who needs it. Thank you.
Thank you so much, sir. Viru?
Yes, madam. Still at 1 minute, 30 seconds, ma'am.
From Arun Kumar, sir, children, male children, maintain hygiene by 1 minute.
Retracting the prepuce.
By retracting the penis regularly. That is what sir is advising. Avoid deodorants, avoid soaps and perfumes.
Yes. And cleaning also for women, it should be clean from the front to back, not from the back to front. And regular cleaning of the prepuce, even from the age of 6 years. And they can use a simple water. No need to use very strong soap. Yeah, that should be avoided.
Female needs cleaning after every time toileting, after toileting. That is very important. Because the last part of the urine will be dribbling and things, contamination.
Kavita, Dr. Menstrual hygiene also.
Menstrual hygiene for women, children. Avoid drug and sex.
You can release the quiz.
Avoid using sex toys. Viru, is the time over?
Madam, time is up. I will.
You can release the key. Thank you so much, sir, Arun Kumar, sir, for your valuable inputs regarding the genital health awareness.
Arun sir, we know that you are from UK, so maybe some technical problems, but we have received your message and it has communicated to all the delegates, those who have participated. Almost more than 240 delegates have participated.
So the quiz answers are like this. In disorders of sexuality and sexual functioning, the term paraphilia refers to sexual urges or fantasies involving unusual sources of gratification problems. B is the correct answer. The term performance anxiety refers to fear of failing to achieve a sustained erection. In men, erectile dysfunction is associated with high levels of which of the following? It is high levels of prolactin. So male erectile dysfunction. The act of exposing in a public or semi-public context those parts of one's body that are not normally exposed is called as exhibitionism. The squeeze technique was devised for the treatment of premature ejaculation. PLI-SSIT model of sex therapy was created by Jack and Anon. Sexual health is for procreation, recreation, relation. Is it relation? To maintain relations. So all of the above is the answer. Dyspareunia in a woman is due to estrogen deficiency. Lena is worried since she has not enjoyed sex from the time of birth of a child. She does not feel even it is as pleasurable as it is described by her friends. This is an example of orgasmic disorder. The latest classification of female sexual disorder is by DSM-5. Requirements for DSM is the duration should be 6 months, frequency 75 to 100%, significant distress. So answer is all the above should be present. Female Viagra ADDY contains fibenicerin, flibanserin. Hypothyroidism causes decreased libido, depression, weight gain. So all of the above it causes. Botox injection is used to treat. It is used to treat vaginismus. So please release the So the winners of this Astinar-6 are among the postgraduates. It is Dr. Kalaivani from Madras Medical College and Dr. Juhi Fatima from Deccan Medical College. And among the senior residents, Dr. Praveen Kumar Boppani from Railway Central Hospital, Lalaguda, and Dr. Prashanti from Government Medical College. So, hearty congratulations to all the professors and the staff and the faculty who are involved for the winning of all these postgraduates and senior residents. So, hearty congratulations to you all. I now invite, yes, sir.
Before that, hearty congratulations to all of you. And now we have conducted six Astinar stars. And which college will get maximum winning prizes from PG side as well as from senior resident side. So their the PGs or SRs along with their HODs and faculty will be honored physically at Hyderabad.
Thank you, sir. So I now invite Dr. V. Mohan Kumar sir, our Honorable General Secretary, to propose vote of thanks.
Thank you, Madam. On behalf of our IAS study, my sincere thanks to our chairpersons, Professor Surya Narayana sir and PV Pai sir for conducting this Astinar on sexuality in a successful manner. Our sincere thanks to the female sexual dysfunctions panel, moderated by Professor Batni Madam and Dr. Neelima Madam and Professor Vasuki and Shobani sir and Dr. Prashanagad in excellent manners. Then my sincere thanks to the second panel discussion on male sexual disorders by our solvers, Professor Venkatraman sir and our President sir, and Uday Kumar sir and Sai Krishna sir. And once again, my sincere thanks to our Master of Ceremony of the Day and Quiz Master, Professor Kavita Madam, and our assistant, my teacher, Professor Arun Kumar sir, for Astinar Star of the Day. And once again, on behalf of our association, my sincere thanks to the unconditional support from Petro Healthcare for this making Astinar an excellent platform in disseminating the STI awareness and academic knowledge towards the SURI resistance and the PG students. Once again, my sincere thanks to our Astikan Hyderabad team led by our stalwart Professor Mehta sir, Venkatraman sir, and our organizing legend Dr. Bhumesh Kumar sir, and the team Astikan Hyderabad for making this Astinar 6 successful one. Once again, on behalf of our association, I request all the faculty members and the participants of the day to participate in Astikan Hyderabad in September 9, 10, 11, and making this Astikan Hyderabad a memorable one for all. Thank you once again. Over to you, Madam.
Yeah, I thank.
Thank you, Madam. Thank you.
Thank you, sir. Thank you all.
Thank you, everyone. Thank you.
Very nice evening.
Good night.
Thank you.
Thank you.
See you physically in the Astinar.
Yes.
Thank you.
Thank you, Madam.
Thank you, one and all.
Thank you, sir.
Thank you, sir. Thank you, Miss. Thank you.
Good night, sir.
Good night, sir. Good night. Thank you, sir. Mehta sir.
Good night, sir.
Sobani sir. Thank you, Sobani sir.
Okay, sir.
Thank you, one and all. So thank you very much, sir.